Hi everyone and welcome to tonight's webinar. Tonight's topic is on titration, protocols that improve outcomes and patient comfort. To guide us through this topic, I'm thrilled to introduce Christopher Panton. Christopher is an experienced clinician in dental sleep medicine and has been working in the industry for over 35 years. Tonight, he'll be sharing his insights and strategies that can help practices like yours get better results and ultimately happier patients. So without further ado, Christopher, welcome and thank you very much for being here.
Cool. Thanks, Nick. Can you actually hear me?
We can hear you, yes.
Beautiful. Okay, so thanks, guys. You've probably all been at work all day and probably tired. So I hope this is a bit stimulating for the end of the day. There is no magic potions at the end of this lecture that is going to make titration any easier for you, but at least you'll be able to introduce strategies with greater knowledge. So what is it and why do we need it? And what are some protocols we can use? And more importantly, what adjuncts and combination therapies can we use to get better outcomes for our patients? So the word titration in the case of CPAP treatment for treatment of obstructive sleep apnea just means to slowly increase the pressure from a continuous positive airway pressure device or any other PAP device. As you would know, there's APAP, BPAP, BiPAP, there's all sorts of PAP, until reaching the best setting to improve subjective and objective outcomes. In the case of mandibular advancement splints, it generally means to increase the protrusion of the splint until reaching the best setting for a particular patient to improve subjective and objective outcomes. So it's very simple. Well, it sounds very simple. It sounds like all you have to do is make a splint and turn the screws and everything will be good. But we'll find out by the end of the lecture that that's actually not necessarily the case. Okay, so if we compare the two treatment modalities, which are the most efficacious treatment modalities for treating obstructive sleep apnea and snoring, we can compare their mechanism. Ultimately, the outcome is the same, but the mechanisms are completely different. So with CPAP, we're looking at a pneumatic splint, which stabilizes the airway by putting pressured air into the airway during sleep. The technology over the years, so CPAP basically, I think was invented in about 1985, has been modified over the years for different reasons to get better outcomes and to improve compliance. So what hasn't changed is the efficacy of it. So the efficacy has always been good. What most of the work for CPAP has been on is actually compliance, because most people don't like it. It has about a 50% compliance at 5 years. Oral appliances, on the other hand, such as mandibular advancement splints, enlarge the airway and stabilize the oropharyngeal muscles. So a completely different mechanism, but trying to achieve the same outcome of stenting the airway during sleep. Technology has been modified over the years. Splints have been probably around since, well, as long as CPAP really, about 1985. The first published ones on mandibular advancement splints was about that time, and prior to that it was actually the tongue retaining devices, which preceded mandibular advancement splints. So over the years, we've increased the efficacy, but the compliance has always been good. So how we discuss the difference between oral appliances and CPAP is that one's efficacious or more efficacious, but the other one's more effective. So we're going to see later there is actually an index to prove that. So down below, we call that the mean disease alleviation, and that is comparable between the two treatment sources. And then when we look at an index, the SARA index, which is looking at residual apnea-hypopnea index. During treatment, they're also about the same. The reason being that we're looking at treatment over time as a function of time. So people wear their splint longer, even though it may not control parameters such as AHI as well, but they wear it for a longer time, so they're treated longer. Whereas CPAP, they tend to wear it for a shorter time, and in fact, in CPAP, 4 hours compliance is considered compliant, but it's more efficacious. So it's more efficacious, but for a shorter time, and the net result is they have a comparable MDA. Okay, so efficacy varies upon different clinical situations, such as the body, the neck position, the jaw position, the sleep stage, weight, alcohol consumption, and the list just goes on. So with CPAP, the pressure requirements are dynamic in nature and may change through the night, between nights, on a short and long-term basis, mainly because of the variation in all those features above. With the splint, it's actually protrusion requirements that are dynamic in nature and may change through the night, between nights, in the short and long-term basis. The only difference is that we can achieve that with CPAP more easily, especially with things like APAP, that the pressure varies on demand, whereas with the splint, we don't have that luxury. So splints are more like CPAP in that CPAP is a continuous pressure throughout the whole night, except for ramping, of course, if you want to get technical. But basically, it's a constant pressure. And then the splint, it's very difficult to adjust a splint in your sleep. So they tend to be a fixed position for the whole night as well. Okay, so this is a cross between a plug and something very interesting. So this is a splint that we developed that has, to a degree, overcome the issues of splints not being auto-titratable. So this has been researched and developed by the Good Sleep Company from a patent that is my patent. So essentially, the mechanism of this, what differs it from every other splint, is that it relies on the change in muscle tone during stages of sleep, particularly REM. So a lot of patients who have REM-related obstructive sleep apnea do very well on this type of splint because they obviously could benefit and do benefit from further protrusion in REM to overcome the increased number of obstructions they have during REM. So that's just a little plug, but also something very interesting, especially we've been working with a neurologist here in Perth, and a lot of migraine sufferers have REM-related obstructive sleep apnea, and they're quite refractory to medication, to headache medication. And so there's some excitement around a treatment that will help those patients who have REM-related obstructive sleep apnea related to the migraine headaches. Okay, so mandibular advancement splints can be dichotomized into monoblock and titratable appliances. So what is titratable? Well, we don't see many monoblocks around lately, but just to be thorough, and because I don't know the audience I'm speaking to, I'm going to start at the beginning. You often need to know the history before you know where you're going. So a titratable appliance refers to an oral appliance which has a mechanism that allows the mandible to be advanced in increments of 1 millimetre or less with a protrusive adjustment range of at least 5 millimetres. In addition, reversal of the advancement must be possible. The protrusive setting must be verifiable. Now, this came out from the American Academy of Dental Sleep Medicine in about 2014, defining what an effective oral appliance is. Of course, the splint that I patented completely is a disruptor against these dogmas. Okay, so why do we even need titration? Why can't we just, use a boil and bite that's not particularly adjustable and blah, blah, blah. Okay, so this is looking at some evidence suggesting that there was protrusion of the mandible is essential for effect, and only keeping the mouth closed is not enough. So when we look up there, it was a randomized parallel trial, 81 patients. The mandibular non-advanced appliance, which just kept the mouth closed without protrusion, did change the AHI, but very minimally, from 32 to 31. And then the advancement of the jaw, which was averaged at 74% protrusion, made a significant drop from 39 to 25 events per hour. So that tells us that, and this is repeated over and over again, this is just one study to give some evidence of why we even bother. Okay, then this is a nice study as well. What this tells us is that the more severe your sleep apnea, the more necessary it is to have an adjustable appliance. So if we look at the 5 to 9, AHI of 5 to 9, the very first bars on the very left, there wasn't that much difference between an adjustable appliance and a fixed appliance. But as the severity of the obstructive sleep apnea increased, it became more necessary. Okay, titration protocols. There aren't any, but we will go through and, well, that's not true, there are some, but there's no standardized titration protocols and there's no gold standard of titration protocols. So the holy grail really in dental sleep medicine is, well, one of them is predicting who a mandibular advancement splint will work in. And the second one is how far do we need to protrude the mandible to achieve an outcome. So this is referring really to the second holy grail. Where do we start and where do we stop? So some studies suggest more protrusion is better, i.e. the improvement in symptoms are completely dose dependent and basically limited by the patient's ability to protrude. Other studies suggest greater protrusion does not always reduce the AHI, and we're going to be seeing this also a little bit later. Okay, so what are we aiming for when we are titrating? Again, we like to compare everything back to CPAP because CPAP is the gold standard. So you want to be comparing yourself to the gold standard, not something less, especially that mandibular advancement splints are still, in spite of how well researched they are, mandibular advancement splint treatment for snoring and obstructive sleep apnea actually has more peer-reviewed papers than CPAP does. So, but it's still not really accepted by sleep specialists universally. So some do like it, some realise there's a place for it and it's a great plan B, etc., but it's not greatly loved. So with CPAP, the idea is to maintain the lowest possible pressure to maintain the airway during sleep. That's for increased patient comfort and hence increased patient compliance. With mandibular advancement splints, is to maintain the minimum possible advancement, again, to increase patient comfort and obviously improve patient compliance. Okay, so this was a study done by Cato, looking at the dose-dependent effects of MAS on pharyngeal mechanics and nocturnal oxygenation in patients with SDB. So looking at those, he basically protruded the mandible in 2 mm increments. And it's not too hard, especially if we look at the oxygen desaturation index, the top line. You can see that it actually improved with that incremental increase in protrusion. Also, the time spent with a desaturation below 90 also decreased. So what was suggested as an outcome of this study was that a 20% improvement in the number and severity of nocturnal desaturations can be expected for each 2 mm of anterior advancement. So theoretically, you should keep going until you get to 8 or 10 mm protrusion. Maybe that would completely improve the oxygen desaturation. So again, it showed that in fact it was a linear improvement, and as I just mentioned, that 100% improvement could be expected with a 10 mm advancement. Unfortunately, the research did not advance mandible beyond 6 mm, and it was just implied it was linear, and so started the thought process that more is more, meaning the more you protrude the mandible, the better the outcome you will achieve. So where do we start and where do we stop? So commonly, we start at 40 to 80% of maximum protrusion, or 40 to 80% of the range. And those of you working in the area will know that certain splints manufacturers recommend different protrusions. There are studies out, there's many studies out to show that you don't need to go over 50% to get an outcome, etc. The next thing is less than 5 mm is considered ineffective, but this certainly is not validated. So anyone working in the area with a patient whose range is only 5 mm should not be deterred from considering mandibular advancement splints as a treatment for their patient. The risk is, if it's too little, if you don't start far enough forward, the symptoms remain too long. So then the patients lose interest, and in fact, the splints actually may require resetting. So it's really important not to start too far back. Now, you're probably thinking, what does the resetting mean? It means that if your splint only has a 5 mm range, but you have started too far back, you will probably run out of adjustment before you potentially get the outcome the patient's after. So therefore, you'd have to reset the splint further forward. Start protrusion in small increments after acclimatization. That's the other really big point. Not to choose a splint also that has large jumps in their adjustment, and advance until snoring is resolved and it's not uncomfortable. So that's usually the sort of protocol that most people have followed for many years. And we're going to move on. It's not quite that simple now, but that's a nice simple way to do it if you're starting in the area and you don't want to use technology or anything. And then where do you stop? You stop until patients are no longer sleepy, because that is a very important symptom of obstructive sleep apnea. And you can use things like Epworth Sleepiness Score or the new PROMIS score, which is probably more robust than Epworth Sleepiness Score. Again, stop when snoring is resolved, improvement in other symptoms such as morning headache, nocturia, and just be aware it may take 3 to 6 months. We're also looking for a reduction in ODA or AHI. I don't know how much training people have in sleep on this seminar, but there's two main things, symptoms of sleep apnea, or two main consequences of sleep apnea. One is the disturbed sleep, and the other one is leading to daytime sleepiness, etc. And then the other one is oxygen desaturation. So when we're looking at ESS, we're looking at sleepiness, and we're looking at ODA, we're looking at how much desaturation there is, trying to minimize the amount of desaturation. We saw that in the Cato study. That's what he used to measure his benefit of protrusion. Okay, so these are the practical considerations for effective oral appliance use for sleep apnea. If a patient reports that snoring, sleepiness, or morning headaches persist without side effects such as tooth pain or jaw muscle pain, a dentist advances the oral appliance. The problem associated with these titration procedures is the time-consuming steps needed and the risk of under-titration because of absence of an objective parameter. Now, that's probably referring more to clinicians who choose to do the titration for their patients. Certainly in my clinic, I've always trained the patients to do their own titration and then review them. Otherwise, it's going to take forever and they'll get sick of it and you'll get sick of it because they're in all the time having to be seen. So in 2016, in a meta-regression analysis of different amounts of mandibular advancement in 13 randomized controlled trials, it showed that greater than 50% do not, that advancement amounts of greater than 50% do not significantly influence the success rate, which was really interesting. So it gets back to the point I made before about some studies showing you don't need to go beyond 50%. I would just take that as a point of interest and not be influenced by that. You need to protrude the mandible as far as you do to get the outcome. So the thing about sleep, treating sleep, especially with mandibular advancement splints, is that it's very personalized medicine. So you are treating every individual. So that's just an interesting aside. It's like saying, well, maybe we should be starting our splints at 40% and certainly maybe no more than 50%, because a lot of patients get a result at that end of protrusion. So Remes in 2013, his study showed effective target protrusion positions were relatively small. The lowest was 6% and the median was 68% of the patient's protrusive range. And this gets back to not suggesting that less than 5 millimeters isn't going to work. And it's also telling us that the median is significantly greater than 50%, and in fact 68%. And there's even consensus that you should start a splint at 70%, which I don't agree with either. Clinically, I just don't see that. Of course, patients end more than that, but that's very personalised. Some patients do not need a large amount of advancement and their devices may be over-protruding the mandible. This gets back to the point of where you start and not starting too far forward, but not starting too far back. So you can see I've not really told you anything so far, because this is what titration is. There are no gold standards, there are no rules. You just need to be aware of what the science tells us and what clinical experience tells us. Okay, and this is following on still. So too much advancement increases the risk of side effects, although it is clearly important to achieve an optimized outcome. I guess in Japan they might be more stoic than others, and they can put up the pain, but the pain will limit how far you can protrude the mandible. Although if you do it slowly and carefully, most patients do acclimatise surprisingly well to large protrusions. Titration procedure is not currently standardised, as I just said. One review classified the titration procedures for OSA as following, and this is actually a very good way to do it. So basically, we're looking at subjective titration, purely based on the physical limits of the patient and indicated by self-reported evolution of symptoms and cyclical. That's not physical limits, that's cyclical limits. The next one is objective, which is initial overnight titration of the splint during polysomnography. That's probably the gold standard of titration, but not practical. And then multi-parametric titration, which is what we are probably doing now more commonly, which is a combination of subjective and objective findings using a single channel device, a type 3 portable monitoring device, or full polysomnography. Okay, so this is the study that this slide is referring to, Delchin's 2012, and hopefully you will have access to this presentation, and you'll be able to use these references, because this is really worth sifting through. So this is the breakdown of all the options using subjective and objective and multiparametric titration. It's quite wordy, so I'm not going to sit here and read that to you. Here's the studies which have been done, which fall into one or more of those categories, and again, worth reading, but it is pretty heavy going. So we're just going to have a look at a few of the options of titration. So this is looking at titration during polysomnography, either manually or remotely, and during clinical evaluation, symptom-guided, home monitoring, and the two combined. So home monitoring could be a pulse oximeter, symptom-guided would be sleepiness and those scores such as that. How many times you go to the toilet, partner report, all those more subjective things. Okay, so now we're going to look at remotely under sedation. So this is not a feasible thing to do to every patient with a mandibular advancement splint. But what it did do, it was telling us about predicting oral appliance success by looking at the decrease in CPAP pressure. So the patients were sedated, and the idea was that the CPAP pressure required to keep the airway open would decrease as the mandible was moved forward. So essentially, when the CPAP didn't move off the base pressure, it meant that the oral appliance was controlling the airway by itself. Now, we've been able to extrapolate that. In my clinic, we have done a few cases now where we've patients who were on CPAP successfully, so they had acclimatized to CPAP and they were using CPAP as an alternate to mandibular advancement, or they're using mandibular advancement splint rather as an alternate use to CPAP. We basically use their APAP, their auto-set positive airway pressure machine, to help us determine the protrusion of their splint. So this is, you'll see down there, Dion is a sleep tech who works at Somnicare in Perth. And so the idea is the patients are, all their data gets sent through the cloud to the lab, and Dion reports back to the patient if the pressure of the CPAP had moved off its baseline. So basically, in this case, the patient's pressure was set between 4 and 16. And if it didn't move off 4, then the splint was probably in about the right or correct position. And then, of course, they did the normal follow-up with the sleep study, etc. Now, the more experienced people listening to this will go, yeah, but that's all very fine, but 4 centimeters of water pressure in a CPAP may be therapeutic for some people. And you go, well, yeah, you're right. But compared to nothing or partner report, is pretty robust way to measure if the splint's working. So what was cool about this one, and why I use this particular one, is because the patient actually took their splint out at 4 a.m. in the morning. So the box on the lower left of the pressure readout shows the pressure hardly moved off 4 centimeters of water pressure, but as soon as the splint came out, of course, the APAP took over, and the pressure of the APAP went up to compensate for the fact there was no splint in. So in reverse, it's telling us the splint was controlling it well. So I've written up there, we set the minimum pressure on the APAP, the protrusions adjusted and tested on the APAP and reported to the lab via the cloud. The aim is to have minimum increase in PAP pressure from minimum set pressure, and this is only useful for patients already acclimatized to PAP therapy. So there's no point getting someone to hire a CPAP machine to titrate their splint, because of course they have to go through all the acclimatization of the PAP machine. Now, the other way of doing it is to use CPAP, so to use continuous pressure. Now, this is actually probably more useful, and we haven't actually done a lot of these. And we're probably now going to start looking at it more, because the nice thing about CPAP, it actually gives you an AHI. So you don't have to look for moving of pressures and whatnot. And there's some nuances between different CPAP machines. Some, like for instance, ResMed will overcompensate and show a big pressure change when in fact there probably didn't need to be big pressure change. So that can be a bit of a furphy. But CPAP's great because it just gives you an AHI. So the patient adjusts the splint, gets told what the AHI was, adjusts it again, you know, as they adjust the splint. Something I didn't stress is, of course, you're wearing the splint and the PAP machine together. You're not wearing one and then the other, you're wearing them together. Okay, so during full PSG manually. So this is a study that basically the EMAT was a trial appliance, and it was titrated during the night in a PSG, and they found that 9 of the subjects were actually responders. 43% had decrease in AHI, but that unfortunately was not related to long-term success. After they went to the study to find out what their titration, or that they'd be suitable, or what the protrusion should be, they were then put on a Clearway appliance, which is a relatively old appliance now. And then they had a PSG repeated at target. So at this target protrusion that was determined in the original sleep study with the temporary appliance. 1/3 of the patients did not pursue oral appliance therapy after the titration night. And I would suspect that is because they would have been protruded quite a long way to see the optimal position, and also anything that's not custom made is uncomfortable anyway. So it would be around that, I would suggest. Okay, remotely. So this is a study that was done looking at remotely controlled positioner during sleep, and basically the dotted lines we're looking at. So the idea was they were put into a PSG, and you can see that's remotely adjustable by all sorts of pneumatic means, and the mantle was protruded forward till got an optimum reduction in the RDI, and of course, you know, the RDI is sort of like the AHI, but with rarers included. And then an optimal position, and also, or more importantly, a predictor of whether it was going to work or not, was made. And so the dotted lines represent the patients from the RCMP where they predicted failure, whereas the solid lines represent the patients where the RCMP predicted success. So the interesting thing about that is not many people failed that were predicted to fail. The worst ones, there's one up here that sort of went up a little bit, but not a lot. So then that grew into the matrix, which most people probably know about, which is now commercially viable and is actually quite quite sophisticated now. So in its basic form, they did a study on 67 consecutive patients. They did overnight mandibular titration until they were in REM and the AHI less than 1, which I'm suspicious that's a typo, because it's very hard to get someone to less than 1 in REM. But I guess if they don't obstruct in REM, it is. But anyway, don't worry about that too much. They did follow up with oximetry, and the success rate defined as an ODI less than 10 and a 50% reduction in ODI as well, at least. So what the net result of that was that they predicted success with a mandibular advancement splint in 30 patients, but 2 of them actually failed. And they predicted failure in 5 patients, but in fact, they predicted failure incorrectly in 5 patients because they actually had therapeutic success, and they predicted it correctly in 24 patients. So the only downside to that whole study would be that 5 patients wouldn't have been treated potentially using this outcome. Okay, so titration during PSG and clinical evaluation. So this is a study by Almeida. This is quite a good one. So basically, they had 23 patients with moderate to severe obstructive sleep apnea. They did a baseline diagnostic polysonogram. The oral appliance titration was purely on clinical symptoms, so snoring, how they felt, etc. And then they did a titration PSG. So they defined success as an AHI less than 10 events per hour and reduced by 50%, plus subjective relief of symptoms. So this is using objective and subjective criteria to titrate. Responders achieved success without titration during PSG, and the incomplete responders achieved success after titration PSG, which is quite significant. So this is quite nice pie graph. So we're looking at 3 different possible outcomes of treatment. So here we're looking at an AHI less than or equal to 10 and an RDI less than or equal to 15. Again, here, this is AHI with rarers included. So basically, sleep disturbance, respiratory effort-related arousals over here. Over here, less than equal to 5. Now, this would be pretty much the standard criteria for determining a responder. And then down here, under 10 events per hour, which is probably more the realistic outcome for treating patients who are moderate to severe in sleep apnea. So you can see here, so what they did basically, they got the patients into a PSG, and the technician determined when to wake up the patient and protrude the mandible another millimetre, and they did that 3 times during the night. So they were woken during their sleep study, which is undesirable. Anyway, the good news was that they got pretty much a 95% success rate when you consider the success before the sleep study, the result of the titration during the study, and only like 4.3% didn't respond at all. So that's a pretty good criteria for adjusting a splint. Again, very cumbersome, not really realistic, especially it's hard enough to get a treatment sleep study anyway. Most of you would be aware that they can only be offered by a sleep specialist, legitimately, I should say, by a sleep specialist. What else is really interesting here? Nothing really, just that it's interesting. Okay, there is hope, guys. There will be something coming that will give us hope. So then we look at titration PSG for titrated oral appliances. So this was the blurb after the previous study. Responders and incomplete responders showed no difference in terms of their baseline, age, gender, BMI, sleepiness, AHI, etc. There was an increase in success rates from 65 to 95%, and the sample was on compliant patients, of course. Okay, so symptom-guided anoximetry, that's our next option. So this one is a nice study. This basically shows us that as snoring decreases, sleep apnea also decreases, and also the importance of titration. So there were 66 patients in this study. They started with 7.1 millimetre advancement on the first advancement, which is the black bar. They moved to, 70% of people were controlled. On the second advancement, 24, and by the third advancement, 6% of patients were controlled. So again, telling us why we need to titrate, but also the importance of using simple things like snoring as a guide as to outcomes. Okay, in this study, this was looking at mandibular advancement titration. In this case, it was 40 patients, mean AHI 46, which is actually very high. They're severe sleep apneics. Effective position was defined as resolution of symptoms and reduction in ODI to less than 10 events per hour. As a rule of thumb, an ODI almost goes parallel with AHI. So we'd be looking for an ODI of less than 5, just like with AHI, we're looking for an AHI less than 5. Okay, so 25% of the mandibular advancements were motivated by the abnormal oxygen desaturation index, despite resolution of the symptoms. So in other words, the patients felt great, but their objective feedback was not good. 20% of the mandibular advance was motivated by persistent symptoms with a normal ODI. So they were the opposite. They actually had the airway well controlled for oxygen desaturation, but they might have still felt sleepy or getting up to the loo or all the things that go with symptoms. The high rate of complete, that means AHI 5 or less and partial AHI 21, success rate was 82% with an aggressive titration protocol like this. The good news was that the compliance was really high. So 34 out of 40 patients, nearly 18 months later, was still compliant. And we see that a lot with splints. We quote patients 80% compliance at 5 years compared to CPAP about 50% at 5 years. Now, you can find a dozen studies that will vary those numbers. There's one CPAP study that says it has a non-compliance of 83% at 1 month. So I suggest they change their CPAP provider. That's extremely disappointing. Okay, so we've already seen this study. The other important point out of this is that not every patient requires maximum protrusion, as shown by the fact that some of them required 3 adjustments to get the outcome, even then it wasn't maximum protrusion. Improvement in AHI during oral appliance therapy is dependent on the amount of mandibular protrusion. That's just a no-brainer, but it's also be very aware it doesn't mean more is more. More is better, as we saw way back in this lecture. So the optimum titration. Progressive mandibular advancements are required to achieve the optimal therapeutic position, which improve objective and subjective outcomes. Not every patient needs to be advanced to the maximum forward position, and some patients need minimum or no titration, which means they don't need to be given a head start. The AADSM, which is really the peak body in dental sleep medicine, put out a position statement about portable monitors. So they suggest that portable monitors might be useful to assess short-term efficacy of oral appliance use, and results may be useful in the titration of appliances before referral back to referring physicians for formal follow-up. Now, this is really where we're going. So what do we use oral portable monitors for in oral appliance titration? Well, we use in moderate to severe apnea patients because we know level 4 studies or pulse oximetry studies are not very sensitive in the milder cases of desaturation, but they're very useful in moderate to severe sleep apneic patients. So they're very good for that. They're also good for patients with no or limited symptoms. So we saw in that previous study saying, well, you know, as your snoring drops, your sleep apnea drops. But the problem with that is that not all sleep apneics snore and not all snorers have sleep apnea. So often we have to use something else. Also, it's very good in patients showing no or little improvement. And of course, patients without human bed partners, although some people tell me their dogs are really smart. And then, of course, the final follow-up is always by a physician. All right. So this is looking at a titration protocol that was just put forward by Fernanda Almeida. So she is a very, very important researcher in dental sleep medicine out of the University of British Columbia. Very sensible researcher, very practical research, not completely academic. It's very clinical as well. She's an orthodontist by training. So her thing is to do monthly appointments to ensure good outcome for patients. She titrates according to symptoms of snoring, and you could use something like SnoreLab. Daytime sleepiness, which is their sleepiness score, recording of headaches, and witness apneas by sleeping partners. Is that always enough though? Well, that depends. We've already discussed that in fact we probably need objective and subjective outcome feedback as well to determine the amount of protrusion that's required. So one of the easiest objective things to use is something like SnoreLab. This is based on the fact that we would just mentioned that as snoring decreases, so does sleep apnea. We also mentioned that not all sleep apneics snore. Similarly, not all snorers have sleep apnea, and actually not all sleep apneics significantly desaturate. Clinically, snoring is the most common presenting symptom, and those of you who have done enough, you'll often come across patients saying, I don't care if I die of sleep apnea, just stop my snoring because my wife's leaving me. So snoring is by far the most common presenting symptom. So using something like SnoreLab is actually logical. Evidence indicates snoring reduces in association with reduction in obstructive sleep apnea. However, it's not quantitative. So you can't say SnoreLab score of 0 equals an obstructive sleep apnea AHI of 0. One good thing is that the guys who invented SnoreLab, Julian Goldberg in the UK, is now developing some technology to use sound to measure obstructive sleep apnea, whatever. But even now, you can sync your SnoreLab to wearables such as Apple Watch. So you can measure oxygen desaturation as well as snoring, which is pretty quirky and probably another good way to titrate an appliance if you wanted to. Okay. And this is interesting too. So the intensity of snoring does increase as our OSA becomes more severe. So there's more evidence to suggest that snoring probably is a good parameter to measure with some objective feedback. This is an example of SnoreLab. This is in one of my patients from years ago. He's now 125 kilos. He's a 6'4" bodybuilder. And it's just hard to believe a bit of plastic can achieve that outcome. But he basically sits around a score of 0 when he had his repeat sleep study. Fortunately, his obstructive sleep apnea was also under control. Okay, so this is the sobering slide at the end. So this one is about the risk of over-titrating. So in this case, patients were, there were 52 patients. They had sleep studies at 75% protrusion, and if they didn't have an AHI less than 5, they were then offered another sleep study at 90% protrusion. So you can see from that 17 out of 52 were responders in the first 75% group. Then when it went to 90%, 6 out of that 35 left over were responders. So that's 23 out of 52 were responders because of that. 19 out of the 35 did have a decrease in their AHI, but not to less than 5 compared to the 75%. However, 16 out of 35 at 90%, the AHI actually increased. So the take-home message here is that it is possible to over-titrate and actually increase the apnea-hypopnea index and no doubt make the snoring worse. Now, when you've been doing this work for a long time and you see things like that, you say, well, thank God I'm not stupid, because I have seen this clinically so much about patients over-titrating, and then you wind them back and they actually get an outcome. So just be very aware of that, hence also why the more is not the case, so protruding as far as you can. It doesn't necessarily isn't necessarily a good titration protocol. Okay. Okay, so the effectiveness of oral appliance titration can be improved with a combination of patient subjective evaluation together with its objective assessment, and I think we've seen that. And of course, we're now getting to the more exciting area of hypoxic burden, which now is looking to be maybe a more reliable measure of undesirable or health outcomes in terms of cardiovascular disease. And although at the moment that would be measured in a PSG, I dare say that eventually we're going to be having wearables that allow us to measure our hypoxia burden and to titrate to that, which is really exciting. So I think that'll be the next big step, and I dare say it's probably nearly there. I just want to spend this last bit because that's my hour and I'm on the clock. So I just want to quickly talk about adjunct and combination therapy, because the topic of tonight's webinar wasn't actually necessarily about titration protocols and whatnot. It was how to improve patient outcomes. So naturally, the biggest tool in our box as people working in dental sleep medicine is to protrude the mandible. That's really we're one-trick ponies. What else are we going to do? And if anyone's sitting there going, oh, we're going to, give you a breathe hole out the front and we're going to do this or that, forget it. Anyway, let's just move on. So we're going to look at adjunct therapy because adjunct therapy is so important to getting good outcomes with mandibular advancement splints. And the most common adjunct is actually positional therapy. And if you start looking very carefully at sleep studies, you'll be amazed how supine sleep is have a negative impact on the AHI. So adjunct means as well as. So a treatment as well as a splint. So in this case, we'd be looking at positional therapy, something like, the old-fashioned pillows and all those things, and then things like night shift with a bit of technology that vibrates when you go past 45, I think it's 45 degrees. It'll vibrate and train you not to sleep on your side. So there's a very subtle difference between combination therapy and adjunct therapy. So I consider night shift an adjunct because it's actually training you not to sleep on your back. Now, I put in there limited opening. So this comes to splint design, and there certainly is at least one study by Francesca Milano out of Bologna. And we were always suspicious, especially with appliances that don't have any limit to their opening, that was a negative thing. And thank God she did a study in 2015 that showed that's right. So if you're using any appliances that don't use elastic to limit opening, you should reconsider that, especially in supine. So her study actually was more looking at supine sleepers and the effect of using elastics by limiting the opening. Then we've got weight loss. So weight loss is easy. It's exercise and diet. And then if you insist, you could go to Ozempic or Mounjaro. And it's really interesting because Mounjaro is actually promoting that they lower AHI and they do blah, blah, blah. But the only reason it does that is because it causes weight loss. So I was all excited thinking it was going to change the tone of muscles and all sorts of things, or whatever, arousal thresholds or whatever the things are that disturb your sleep. But in fact, it's all got to do with weight loss. Then we've got sleep hygiene. So no caffeine before bed, alcohol, no blue light. So turn off all the technology. Nasal airway optimization, which is absolutely critical for either CPAP or splint. And that can be done with nasal stents, like things like Mute, Then nasal lavage, which is salt water and bicarb, rinsing out the nose to take away inflammation, etc., mainly for allergic rhinitis, I guess. And then nasal steroids if you have to. I guess the next bit would be to refer to an ENT and have the nasal airway examined to make sure there's no polyps, no deviated septums or enlarged turbinates, etc. Then the last adjunct would be pharmacotherapy and CBT. So COMISA is comorbid insomnia and sleep apnea. So commonly, as you would know, insomnia is sort of divided into sleep onset insomnia, which they believe probably is psychological, although that's questionable now. And then maintenance insomnia, where you can't sleep, is related to perhaps to obstructive events. And it could just be a rarer or anything. But anyway, disturbed sleep from your airway collapsing during sleep. So obviously cognitive behavioral therapy is probably not going to help a lot with that. But certainly with sleep onset insomnia, maybe it is, maybe it's not. And then there's other pharmacotherapies as well, but I'm not going to go into those because most of them are prescribed, not by dentists, but I'm putting in there to be thorough. Okay, so then we can look at combination therapy. So we look at CPAP and MAS. So the idea of that combination is to improve compliance, because one of the many reasons why people don't comply with CPAP is because of CPAP pressure being too high. So wearing MAS as well as CPAP in most cases allows that pressure to drop and therefore increases the compliance of the CPAP. We also know fairly old studies show that mandibular advancement splints and UPPP give a better outcome than either alone. So that would be another combination therapy. And then there's CPAP or MAS and pharmacotherapy. And this is getting into the phenotypes, which I'm not going to get into yet, but I'm putting that up because those of you who are more advanced may want to start looking at that, because a lot of work's been done on drugs for obstructive sleep apnea. And the last combination therapy I'm going to put in there is mandibular advancement splint and hypoglossal nerve stimulation. And certainly where I am in the Centre for Sleep Science, we were heavily involved in some of those early studies and can vouch for that as a viable treatment option. Okay, oh, look at that, bon nuit. So it looks like it's time to go home. And I hope you've taken something out of that. I reckon I probably confused you more than I made it clear on titration for splints, but that is a good thing, because now you're going to go and read and think a little bit laterally and improve your patient outcomes.
Thank you everyone for taking the time to watch this webinar. And thank you, Christopher. It's very much appreciated.
Pleasure. Speak soon.